Hello. For those of you who I have not yet met, my name is Dr. Kit Dobson. I'm a professor of clinical psychology at the University of Calgary in Canada, and I'm also the current president of the World Confederation of Cognitive and Behavioral Therapies. I've been invited today to give a presentation to the Belarusian Association of CBT, and it's my privilege to do so. Let me start my screen share, and I'll be able to give you the presentation. So it should have just gone live. And as you can see, the title for my presentation is The Dissemination of the Cognitive Behavioral Therapies, and why I've come to believe in particular that this is really a global imperative and affects all regions of the world. Again, my presentation again is to you in particular, but this talk I have been giving in other places as well, because it's very germane to all parts of the world. Let me give you a bit of a brief presentation outline. So what I want to do is very briefly talk about why is mental health important. This is not news for most of us, of course, and I'm sure is something that people in your country are well aware of. Talk a little bit about the evidence base for CBTs in general, and a little bit of the transition from efficacy to effectiveness studies and why that's an important link. And then I'm going to talk at the end in particular with some suggestions about why and how CBT can grow globally. So very briefly, why is mental health important? Well, we know, of course, that many people in the world struggle with mental health problems, as I'll talk about. When we look at the organizational structure for mental health services, though, we find that they're actually quite deficient. So in 2019, of the World Health Organization member states, only half reported that they had a policy that aligned their plan for mental health with the international and regional human rights instruments. So only half met about regional health standards. And only about 19% of the World Health Organization member states were able to say that they could monitor the implementation of the components of their policies and practices. So only half met the international global standards, only 20% approximately could monitor the work they were doing. We also know that the public expenditure on mental health services is extremely low globally. It varies dramatically, of course, depending on the country and the economic standing of the country. But again, that the median number of global mental health workers, is 13 per 100,000 population, with extreme variation. So very low. We also know that only 25% approximately of World Health Organization countries have integrated their mental health services into primary health care. So in the other countries, either there is no mental health service, it's not integrated, or it stands as a sort of a standalone orphaned system. Basically, the funding and the structure for mental health services globally is weak and varies dramatically by country, but in some countries is almost non-existent. And interestingly, even though these statistics are quite discouraging, they're actually much better than they were for the previous survey of the type in 2014. When we look at rates, again, of estimated mental health disorders, based on, again, the World Health Organization data, the most current ones from last year, we know that the global rates of a wide variety of mental disorders is huge. And I'm not going to go through all of these. You can look at them on the slide, but I'll just pick depression, for example. Almost 250 million people in the world are estimated to meet criteria for major or clinical depression. My own suspicion is, in fact, that this is a low estimate. But it's the single most common single mental disorder in the world and is a global leading cause of disability. This has been recognized by many countries around the world. And the surprising part, of course, is that we have very effective cognitive behavioral therapy interventions for a wide variety of these conditions, as I'll talk about. So, as bad as those numbers are, we actually estimate that the rates of many mental disorders have increased in the past couple of years due to the pandemic. So of course we know that there's been enormous structural change and problems globally in terms of the economic development and the workability of a variety of people around the world. We also know that even if you don't look at mental disorders and just look at sort of issues related to mental stress, things like domestic violence, obesity, social avoidance, these rates have also gone up dramatically. Even worse, we know that especially with issues related to global warming, for example, and refugeeism, war, the unfortunate invasion of Ukraine, for example, and all of the displaced people in that, your part of the world, violence in other parts of the world, that again, there are increased rates of refugeeism and trauma, which again are not typically caught in some of the estimates of mental health problems because of the disruption, the social disruption associated. So as high as the estimates are of mental health problems, they're probably an underestimate, in fact, of the true distress that we see globally. So we've been trying to move the field over the number of years towards evidence-based practice. And of course, this is not unique to mental health. This is all areas of health, trying to, as much as possible, move the field in that direction. And we've had some success. In fact, there's models now for the development of evidence-based practices in psychological services and psychotherapy. This model is just one. It's the one that I like in particular. It's by the Canadian Psychological Association, but it talks about a hierarchy of evidence that we can build towards to know whether or not interventions are successful. So starting with unpublished data or just sort of common opinion based amongst professionals working in the field, working up to expert consensus, primary research studies, more demanding research studies, that have high measures of internal and external validity, and then eventually to synthetic reviews, including meta-analysis and other statistical techniques to see whether or not interventions work for different populations or different parts of the world. And we're at a point now in the field of CBT generally where we're publishing many meta-analyses. So we're actually able to look at a wide variety of different interventions in different parts of the world with different populations, with different characteristics, and know where the interventions seem to work better or not. And we're at a point again in the field where we know that CBT is actually, if not one of the available therapies, but often the therapy of choice for a wide variety of conditions. So this is a success. We also know that it's not just the interventions themselves, of course, that lead to outcome, but we know that there are a number of setting conditions or therapy conditions that are associated with better outcomes. So the American Psychological Association in 2006 actually had a task force looking at a variety of evidence, types of evidence that support the use of therapies in general, and CBT generally functions extremely well. CBT is an evidence-based therapy now for a wide variety of problems. This list are some of the notable examples where CBT has actually shown great evidence. And I would argue at this point, for example, in social anxiety disorder, specific phobias, and even panic disorder, CBT is the therapy of choice. It has the best outcomes and the longest outcomes of any particular therapy that could be offered for these conditions. And even in areas like major depression, CBT has equal outcomes to any other evidence-based therapy, and relative, for example, to pharmacotherapy, has better long-term results. So actually, for that reason, I would argue again, should be the gold standard or the treatment of choice for people with major depression. Again, not to say that other therapies don't work or can't work, but again, the evidence base is strong, I'll say that. The other thing that's happening, of course, within the field of CBT is we're now starting to see the development and evaluation of different models, even within the overall field. So, the development of acceptance and commitment therapy, for example, is a specific intervention for people with trauma, as opposed to dialectic and behavior therapy, which was developed for people with borderline personality disorder, often who also struggle with trauma. So we're getting different models that could potentially be applied to people with similar kinds of presenting problems. So the field is growing well, I would argue. How does CBT work? Well, we actually know a lot, again, about the mechanisms of change. We know that there are intervention factors, so things that we can do with our clients that help them to improve in the various problems. We know, and there's again a good evidence base, that there are relationship factors that are involved in CBT. So issues like collaborative empiricism, psychoeducation, the therapeutic relationship generally, sort of building a positive, encouraging relationship. We know that client factors are involved. We know, for example, that clients with less severe problems, less chronic problems, tend to do better in CBT, as they do for most therapies, which again suggests that we should be trying to assess and intervene as early as possible in the life cycle of people with distress. And finally, we know that there are therapist factors involved. And in particular, I think the one that's been looked at extensively is adherence and competence. So the extent to which the therapist actually follows the treatment protocols and are competent in doing so. And competence here is a higher order construct. It includes the idea not only that the therapist knows how to do the intervention, but sometimes when not to do the intervention, or when to switch gears and potentially try something different if the first intervention is not working. So all of these factors work together to create the outcomes that we see in CBT. And we do have to recognize, of course, that not everybody improves. So client outcome is not 100%. So there are often people with residual symptoms, and unfortunately, there are some people that in fact don't respond and might need another form of therapy. But in general, the approach is highly successful. You would think, given that the evidence is strong and we have this powerful data, and we know relatively well about some of these non-specific factors like therapist factors and relationship factors, that dissemination should be, quote unquote, fairly straightforward, that we should be able to take these models and apply them basically everywhere. Yeah. So what are some of the obstacles? Because there actually, and again, when I think as a field, we need to recognize these obstacles to be able to address them. Well, there are a number of concerns that have been raised with empirically supported therapies and the CBTs in particular. So, for example, it's been argued that these treatments are biased towards short-term approaches and outcomes that lend themselves to specific outcomes, like, for example, phobias, that it's very clear when a phobia is treated because you have a behavioral outcome, and the treatment can be quite short and quite effective. And so the argument is that the evaluations and the therapies are sort of biased in that direction. I think that may have been a criticism that was valid some years ago, but in fact, if we look at the treatments of CBTs nowadays, you cannot think of a disorder that is not being approached using a CBT, at least one model. I'll put it the other way. The CBTs are being applied across the wide range of different mental health problems. They're also being applied for people with comorbid mental and physical health problems, or people with comorbid mental health issues. So this criticism certainly is no longer valid if it was once. The idea that there's a limited focus on the therapeutic relationship. Again, if you go back and look at some of the early treatment manuals from the 1970s and 1980s, there actually is limited discussion of the therapeutic relationship, but it's there. Even, for example, the very first book on cognitive therapy of depression, published in 1979, there's an entire chapter devoted to the therapeutic relationship. So this criticism, again, to my mind, is not valid, but I've certainly heard it. Yeah, and even notwithstanding that, if the criticism was valid in the early days, it's certainly not valid today. Most training programs I'm aware of pay particular attention to the collaborative relationship in CBT and how to facilitate and foster positive working alliance. Focus on mechanisms of change. Again, it used to be, I think, the criticism that we did CBT to our clients, that we sort of brought them in and do our interventions. And again, I think that's not a valid criticism in any day, but certainly nowadays, the therapy and the therapy relationship and the art of therapy is recognized and is part of our understanding about the mechanisms. Rigidity, lack of art, I've already spoken to that, I think is not a valid criticism. The idea that we didn't really know that much about treatment fidelity. This again is the issues of adherence and competence and how they relate to outcome. That was true in the early days. We didn't know necessarily the best methods to train CBT therapists or how to measure their competence to do therapy. That's not true today. We have measures of both adherence and competence, and there is now a fairly substantial database suggesting that both are related to outcome in CBT, suggesting that the training enterprise is important and making sure that therapists actually do the therapy in order to get the outcomes is also important. Training and credentialing, I've already talked about that a little bit. I'll just talk a bit more about credentialing, though. This has become quite a hot topic within the CBTs because in some countries, there are national systems now to credential CBT therapists. In Canada, where I live, for example, the Canadian Association of CBT is now offering a credentialing system to recognize people who have been properly qualified. The World Confederation, which I mentioned previously, and I'll get back to, is also now looking at training standards for global dissemination of CBT. So this is an issue that still is in development for sure. And then a big issue is the issue of generalizability. Again, as I'll say later again, many of the therapies in CBT were developed in Western cultures. North America, Canada, the United States, Australia, England, and then they've been, in some instances, just simply applied in other countries without much consideration towards cultural variation or age variation and so on. That's changed a lot. So there's now a lot of research that's being done on cultural adaptation and cultural specificity of different interventions and looking at how well therapies work in different countries. And I'll talk a little bit more about that issue because, again, that's an ongoing area of work. Why is cross-cultural psychology important? Again, not to get into a whole dialogue about cross-cultural psychology, but we know, again, that there are different perspectives. So the absolutist idea, that Western psychology and Western ways of thinking about the world are the only way is obviously not appropriate. On the other hand, the idea about extreme cultural relativism, that every culture is unique and every culture needs to develop its own idiographic, specific interventions, probably is overstated as well. So what I think most of us in the field have come to is a position of what's sometimes referred to as universalism, which I think sort of overstates the issue, but basically the idea that there are some universal principles in the way that we behave as humans. The fact that we have thoughts and that our thoughts dictate our feelings and emotional behavioral responses as a principle, probably is universal. The content of that, of course, is culturally defined and is more localized. So again, there are probably some general principles that we can look at even at the level of content. But what this argues for is what most people recognize as cross-cultural psychology. So the idea that there are standard principles and procedures we can use, but that again, the content itself needs to be culturally and even individually contextualized so that we understand the individual in his or her cultural context. As an example, if you think about a therapy that was developed in Canada, for example, I'll just use here, and was developed and evaluated here and seems to have good evidence, you probably would develop a treatment manual or treatment guidance, about how that therapy works, and you would be able to measure whether or not therapists were being true to that model. This would be high fidelity. So on this picture, this would be sort of at the extreme left side of the diagram. So somebody presenting with high fidelity. If you take that therapy, though, and you move it to another culture, imagine you bring it to the Belarusia and you want to apply it there. Well, then you have to question about whether or not you have good fit. Does the therapy that was developed here, does it apply equally well? And how much adaptation might you need to do? So there may be the need for extreme fit in some instances where there's high cultural specificity, which would be on the extreme right side of this particular diagram. So there's this sort of dynamic interaction between the original source and the fidelity to the true model or the original model versus the fit to the cultural context. And you can imagine a variety of possibilities. So here's an intervention that has relatively high fidelity but low fit, and might have, as a consequence, good outcome, or it might actually do quite poorly in the new context because of the lack of cultural fit. You can imagine another circumstance where you have had to adapt the therapy quite a bit. So it may have relatively low fidelity to the original model, but it has good cultural fit. And so you can adapt therapies and make decisions about whether or not, as you move a treatment from one context to another, either cultural context, national context, even linguistic groups and so on, you can determine how much you need to modify the intervention to find out whether or not the treatment actually works in the new context. The general bias I think we have in CBT is that, generally speaking, we should start with high fidelity, relatively low fit applications. You make sure that the treatment model itself is being respected. But then if the therapy is not working as well, you need to do more cultural fit and more cultural adaptation to get the outcomes that are ideal. And this has been going on. This work has already started, and there are people publishing in this area. So this book, again, if you don't know it, it's quite a good one, talking about CBT in non-Western cultures. So again, making the argument that this book does that CBTs began largely in Western cultures, but are being adapted and being evaluated. It's interesting, I'm involved right now in a meta-analysis we're doing of CBT in China relative to the Western world. Again, looking at whether or not CBT is equally or less or more effective. And it turns out, based on the meta-analysis data that we've been able to find, that CBT actually works better, significantly better in China than it does in other countries. And so we're now looking at what are some of the characteristics of CBT and how it's been adapted, perhaps, that allow it to have better outcomes, and whether or not those characteristics can maybe be re-imported into Western cultures to actually improve our success rates here. So anyway, there's a lot of work, like I said, going on in this domain. So how do we take this database and move forward? Well, I think there's a lot of strategies that we can adopt and a lot of things that we can do as a cultural or, sort of the CBT field to make the world a better place. We need to definitely do more dissemination and effectiveness research. So we can, take our treatments that we are developed and seem to work in one context and import them elsewhere, and again, test them and see how well they do in other places. There is a process called benchmarking. Benchmarking is, again, where you take a standardized measure in the original place where the treatment was developed, and you apply the same measure in a different context and see whether or not you can actually get results that are similar, equal to, or better potentially than the original context. So there actually is a published methodology for doing benchmarking research in psychotherapy. The traditional way we've often thought about this is that we start with a theory, that's our base or our groundwork. We then do our efficacy trials, find out whether or not the therapy works, has some kind of measurable outcome, and then we apply it in the field. We do effectiveness research and see whether or not the treatment works in real life populations or in new cultures, new contexts, this idea. We're at a point now in the field where, in fact, the model is more like this. So we have a theory that's out there, of course, and again, there are more specific CBT theories or sub-theories. We've done many efficacy trials. We're now in the process of doing many effectiveness trials, and some of this information is now feeding back into theory and the way that we think about the treatments and why they work. So trying to understand better about theory. Great example here, I think, is in the field or the domain of the non-specific factors in CBT. Like I said, in the early days, the notion was that we just needed to modify people's thinking and behavior and we could get them to function better. That was put into efficacy trials. We recognized when we went into the field that the relationship was more important perhaps than it had been first thought about. That has now been worked into our manuals and our theories, and our efficacy trials now incorporate those kinds of feedback. So we're now into the process of a kind of a virtual cycle looking at the interaction among theory of efficacy and effectiveness, which is great. We need to do more. And again, for dissemination and effectiveness research, so looking at how the therapies work in different contexts, we need to know what our outcomes are. So we need to identify our desired outcomes. We need to potentially do cultural adaptations, as I was talking about, this fidelity versus fit dynamic. We need to make sure that once we know what a treatment is, that when people are testing it in new contexts, that they're trained well so that they can do it with adherence, so actually doing what the therapy says and not doing other things, and that they're doing it in a competent way for the context or place in which they're working. We need to make sure that the right people are getting the treatment. So we need to make sure that we include the right people and we exclude people who probably won't benefit if possible. We need to do absolutely consistent outcome assessment. We cannot, as a field, have evidence-based practice unless we collect evidence. So it's almost an oxymoron to suggest otherwise. So again, if you're not using standardized measurement in your practices, I encourage you to do so. And if you're doing research, of course, this is almost a given. One of the things I would love to see personally would be a kind of a data repository so that we could take data from all different parts of the world and put them into a data bank and be able to compare our outcomes, and especially to look at individual characteristics, linguistic differences, cultural differences, and to be able to do this work. There's some work like this being done, but it's being done more by individuals than by organizations. So the World Confederation has had a bit of a discussion about this. It's a very expensive thing to do, of course. The World Health Organization, we are arguing, could also be a place to do this, but they don't have a mechanism yet. So we're looking at this idea. But to do this, you'd need to have resources for data analysis, for reporting. You'd have to have some way to synthesize the data and make larger statements, basically. And then the last thing that I think we really need to do is to look at how to give this information back to our funders, granting agencies, and the stakeholders, which in my mind in particular is the public at large. How do we let the public know that CBT works and that they should be demanding essentially this type of service? If we could achieve these kinds of outcomes, I think we would move from having just this virtual cycle where we talk to ourselves as CBT people, but we would have feedback to the public and to our funders and policymakers, and that this in turn would lead to huge demand and huge dissemination. This would give us the opportunity to really make CBT the premier therapy globally. And again, just as a quick example, the World Confederation next year on the World CBT Day, which is April 7th, is going to be doing a global set of presentations using public forums to talk to the public about CBT in an uncertain world. So we've picked this as our theme. And again, the notion being that if we can increase the public's awareness, we can probably increase demand and dissemination. Some ideas then, moving towards evidence-based practice, and I'll talk about this fairly quickly, but there are a number of things that I think we should be doing as a field. We should be doing more effectiveness research, finding out how do the therapies work in practice in different worlds and different contexts, and through different kinds of methods of delivery. We should be looking at CBT in more complex and comorbid presentations, so not just simple problems. We should be also looking at CBT in comparison with pharmacotherapy. Again, most of the comparisons that have been done generally support equal outcome for many disorders or even better outcome for CBT. So I think we shouldn't be shy from looking at those kinds of comparisons as well. We need to be doing prevention. We need to take the models that we have, many of which are being used now for the treatment of acute disorder, and put them into prevention programs and do prevention research. There is work of this type being done, of course. So there is work being done with at-risk populations and with people with early signs of a condition, various conditions. But we can certainly do a lot more of this. This is hard work to get funded and hard work to do. But it would be a logical next step. And of course, from a patient perspective, it could help potentially to prevent much suffering. We need to do more dissemination research in terms of delivery models. One of the things the pandemic has taught us is that CBT can be sometimes effectively delivered through distance therapies. This includes things like websites, distance phone utilization, or Zoom, or other kinds of technologies and apps. My sense of the literature in many areas is that this is very promising, and it's a way to potentially get the treatments out. But a big problem with all of these dissemination methods is the ability of the client to persevere, to basically take the treatment model and continue to do it. In a lot of the research studies, the dropout rates for virtual delivery therapies is quite a bit higher than in-person therapy. And so I think that's a big challenge for technological delivery. But again, this is an area for considerable growth. We need to do a lot more work, I think, in the area of public health and consumerism and media attention. Again, I think we need to look at the demand for services and how we can educate healthcare service agencies and healthcare funders about how we can actually get more service demand. We need to think about how to, again, educate our consumers, the patient populations who need therapy, and how we can get people to be aware of and also to use and demand CBT. Generalizability, I've already talked about this. Again, continuing to do studies looking at how well therapies work and what kinds of adaptations are necessary as we move treatments from one part of the world to another. And training, I've already spoken about. How do we optimally train CBT therapists? For example, should CBT therapists be trained as generalists, to work with adults and children in a wide variety of problems? Or maybe should we have CBT specialists who work in trauma only, for example, or particular patient problems? Again, adherence or competence. Do we want therapists who can follow a manual? Or do we want therapists, again, who have the art of therapy and know when not to use a manual? I would argue the latter, but again, we need to understand better this dynamic relationship. We need to look at, again, the policies around the world in different countries that either facilitate or get in the way of the dissemination of the CBTs. I'll just give a couple of quick examples here. In Australia, a number of years ago now, the federal government decided to provide direct funding to CBT therapists who met certain standards for the work that they did. And the public was advised about this funding, and the demand for services was significantly more than the government ever expected. The annual budget that they had allocated was spent within the first 6 months of the program. And so what they have done, unfortunately, is rather than increase the funding, they've restricted the access. But the program continues in a way that provides unlimited access to people who need CBT therapy to qualified CBT therapists in Australia. A very similar model exists in Germany, where people can, if they're qualified as a psychotherapist, and there are two models that are approved, CBT and psychodynamic therapy. But if you have a qualified therapist, they can bill more or less unrestricted to the government for the services that they provide. In my mind, in fact, the access to services in Germany is too rich, is more than what is warranted. And for example, a recent study looked at Germany and said that the average CBT therapist was providing 52 sessions for a CBT client, which is more than most treatment protocols would indicate. But again, there are different ways to fund potentially. So how should we address these barriers the best? Obviously, there's going to have to be cultural and national differences about this issue, but the issue generally needs to be addressed. One of the organizations I think that has a role to play is the World Confederation of Cognitive and Behavioral Therapies. As I said at the outset, I'm the current president. This organization was really formally launched very recently in 2019. There certainly had been global efforts to work on CBT over a number of years before that. EABCT, the European Association of Cognitive and Behavioral Therapies, in fact, was a precursor and has been a very successful international association for CBTs. But there are other regional groups. There's an Asian association, for example. There's a ALAMOC, the Latin American Association. And what the World Confederation tries to do is bring together these organizations into a global alliance or global working group. So our aim is to promote the health and well-being of people through the scientific development and implementation of evidence-based CBT strategies designed to evaluate, prevent, and treat mental conditions and illness, and to disseminate CBT worldwide. So it's a very ambitious agenda. We know that certain parts of the world are actually very well established in CBT. Other parts of the world have really very little to no development in this area. So some areas need a lot of help in terms of developing this capacity. Some of our strategic plan includes to develop the CBT worldwide. So look for areas where we've got successes and to do dissemination work, and look for areas, again, where we need to do more basic or foundational kind of work. Through the World Confederation, we're sharing information. We have a website, we have materials that are available. During the pandemic, we did a lot of work to different national associations about ways to facilitate dissemination of CBT during the pandemic, for example. We have a worldwide network. We have a website, wccbt.org, which you're welcome to go to, which again is trying to promote resources worldwide. We're trying to and beginning to advocate with other international global organizations. So we've got some preliminary discussions happening with the United Nations and with the World Health Organization. I'm currently sitting on a health advisory group for PAHO, which is the Pan American Health Organization, which is an affiliate of the World Health Organization related to mental health. So again, we're trying to and starting to have some success with inroads about the role of the CBTs globally. We're trying to support CBT through training. We have a training committee that's looking at global standards for adherence and competence in CBT. We expect by June of 2023 that this standards will be made available and again can be used by various countries of the world potentially. EABCT, of course, already has training standards, which you're probably aware of. And so again, different parts of the world, like Europe, for example, which is more developed, may have different standards than the WCCBT standards. We're looking at really setting minimal standards with the idea that over time they could grow. We're also doing some work to facilitate research. We don't have the funds, of course, to actually do research ourselves, but we're trying to ensure that people who are doing work are being recognized. And we have, for example, a Global Leaders Program. We're starting to recognize people who are doing exceptional work in the field of CBT, either practice or research. We also have the World Confederation's World Congress of CBT. So every 3 years, there's a World Congress. This year, unfortunately, it's the 4th year. So last year, we weren't able to do the triannual, but in 2023, in June, is the next World Congress of CBTs, which will be held in early June in Seoul, South Korea. So anybody who's listening to this talk, if you have the interest, you could right now make a submission to the World Congress of CBTs in June. It's the very first few days of June in 2023 in Seoul, South Korea. So you're very much welcome. And I will be there. I'd be happy to meet you in person if you actually get to be there. So overall, I think that the field of psychotherapy has grown fairly dramatically in the last couple of decades, and the field of the CBTs in particular has just taken off. You can look at any domain of psychotherapy research, and you'll see that the CBTs are front and center. This movement towards evidence-based practice, I think, is a way of uniting science and practice and science. So sort of this reciprocal relationship that I talked about, but it does have risks and some potential shortfalls. So we need to be working together as much as possible at the global level to make sure that the communication about successes and failures are being shared. We definitely need more research on efficacy, effectiveness, and especially, like I said, dissemination about how these therapies can work in different parts. Ideally, we can also integrate this work in the field of what therapies work with the non-specific therapy work on relationship factors. Again, I think that especially in the field of dissemination work in the real world, so to speak, this is where we can especially understand these dynamic relationships. And eventually, what we really want to develop, I think, in the field are what we call evidence-based practice guidelines. So what these are guidelines that are based on the data and what works in different parts of the world and different populations and with different interventions, so looking at this dynamic relationship, but allowing the flexibility and the therapeutic relationship to be used so that these are not rigid, but again, they are guidelines. This is much like what's done in every other area of health practice. And it's the movement that we see happening in the field of psychotherapy as well, I think. And then the final lacuna or area of weakness, I think that we really do need to address is this interaction again between psychotherapy and pharmacotherapy. I haven't talked about it, but we actually know that the average person in the world, if they're diagnosed with a mental health problem, can very easily get access to drugs. So drug therapies are widely available and probably in many parts of the world overprescribed. And part of the rationale for that, of course, is the financial incentive. Drug companies have huge investment in advertising and marketing, and physicians, again, often know that there are medications available. So we don't have that advantage. We need to do more direct work, I think, looking at CBTs relative to pharmacotherapies and potentially showing through evidence, again, that our treatments are as effective or potentially more, as I said. Finally, I think, overall, we need to continue to develop the work that we're doing. We need to feel good about the work that we're doing. We need to do more training. We need to understand, again, how the therapies that we use work in various parts of the world, and we need to communicate better. We need to have better relationships amongst researchers and practitioners around the world. Organizations like the World Confederation, I think, are a great idea. But of course, trying to do this work at a global level is extremely challenging. So this is work that's going to take a long time. We do have to have ongoing dynamic relationships and opportunities like the one that we have today, where different people from different parts of the world can share optimism and hope for the future. So with that, I'm going to end my slide share and just come back for a moment and just again, thank you for the time that you've given me to make this presentation to you. I know that it's a very difficult time for people in Belarusia and sort of regions around Ukraine. So I do hope that as time goes on, conflict can be reduced and that people can take the learning and the work that's going on in your country and other parts of Europe in particular and take them for the best advantage of our clients. So with that, I'll thank you very much for your attention.